हाँ ओके डन ठीक है।
ओके डन। ठीक।
Assalamu alaikum, Zara. Good morning.
Assalamualaikum, Natasha, and everybody else in this seminar.
I know I'm really excited, and I'm going to say all the thank yous in the beginning because to put this together so quickly and for all of you to do your talks so quickly, honestly, is really just a testament to how committed all of you are to this. So it's super. So thank you for being here this morning.
Thank you.
Assalamu alaikum, everybody. It's 11 o'clock. I'd like to welcome you all and thank you for joining. My name is Natasha Anwar. I'm the General Secretary of the Association of Molecular Pathology, and I will be moderating today's session. On behalf of the MMI DSP and AMPP, I'd like to welcome you all today for our session on Mpox, Recognize Early, Test Right, Act Promptly. So we've designed today's session really so that we can bring together clinicians, microbiologists, and those working in diagnostics, specifically molecular diagnostics, to give us an overview and walk us through some of the most important aspects of controlling and containing our current outbreak. So what I'm going to try and do is, if this slide forward, I don't think I need to share this with you. I'm sure everybody's been following the news over the last few weeks, but this is just as of 14 hours ago, the latest headlines in the news, and our cases in Sindh have gone up to 25 now, and unfortunately, sadly, we've had 9 deaths. And this recent outbreak in a neonatal unit has really been the cause of serious concern and the reason why we're here today. But this isn't the first report. There were concerns earlier on a few months back in KPK, and also in February, reports of 2 patients quarantined in Multan. So clearly, response to outbreaks needs to be timely, practical, and coordinated. And I really hope that we can get through our objectives today, which is really to try and help everybody answer all of these questions. And I will come back to this slide at the end in our Q&A session. So when should I suspect Mpox? Who should I test and how? What do I do immediately once I suspect a case? How do we protect high-risk patients and healthcare teams? And is my center prepared to respond effectively? So our session today is kind of broken up into three main areas: recognizing cases, testing, and then responding in a way that protects both patients and healthcare systems. So we're going to move through these 3 areas, and as I move through them, I will introduce each of our speakers individually. And in the interest of time, we will have a question and answer session at the end once all 4 speakers have completed their presentations. But please do share any questions in the comments in the chat box, and we will get to those questions towards the end. So I'm going to stop sharing, and I'm going to introduce our first speaker. So our first session really is focusing on the clinical recognition, which really arguably is the most critical step, because if we don't suspect it, we won't test it and we won't contain it. So I'd like to introduce Dr. Aisha Ilyas, who is an infectious diseases faculty at the Aga Khan University Hospital. She also works as an ID specialist at the National Medical Center and the Daba Kidney Institute and supervises their infection control. Over to you, Dr. Aisha.
Yeah, thank you so much. Am I audible clearly?
Yes, Dr. Aisha, thank you. We can hear you.
Okay, I'll just quickly share my screen.
Dr. Asha, would you like to share your screen?
वही
I
मैं
will
कर
have
रही
to,
हूँ. I'm sending on the.
I will have to make you co-host. Just a second, please. Now you may share your screen, please.
Say. Lukman, is it clear?
जी डॉक्टर आयशा आपकी स्लाइड्स आ रही हैं
Yes,
if you just
yes, it is clear.
So the idea is simple. Since I'm a clinical infectious disease personnel, so we'll go through case-based scenarios to understand the variable presentation of this virus. So the goals are, as I said, it's a simple. I'll give a brief intro to the Mpox. I'll share the facts and figures as to why we are here today, and we'll do a case-based discussion so that besides Mpox, what are the things that we have to keep in mind when approaching a patient. So simply, Mpox is an infection caused by orthopox virus, and people who have had a smallpox immunization in the past protected against this disease also. It was first discovered amongst animal. It was the first human-to-human disease was recognized in 1970 in the Congo in the African continent. And since then, we have had various Mpox events. So this is basically a timeline. So from the initiation, when the disease was first recognized in 1970 in Congo, it became endemic in the Western Central African with frequent outbreaks, and it was mostly spillover of the zoonotic. Then in 2003, there was an outbreak in the United States, but it was also related to the prairie dogs that were brought in from the African continent to the US. It was a contained outbreak also. In 2010 to 2019, there were some sporadic outbreaks here and there within Europe and Singapore, but it was mostly related to travelers bringing in the imported disease. And it was also a contained outbreak. The first global outbreak, when WHO raised an emergency as to all the WHO regions were involved, was announced in 2022 and 2023. This was the first time that a sustained human-to-human transmission was recognized, and the subtype that was more predominantly was the clade 2B, although it has sub-serotypes and many serotypes co-circulate in the given time period. And here we are in the current situation, 2024-25. This is again a global outbreak, and it has also caused a sustained human-to-human transmission. In this outbreak within Pakistan, we have actually seen nosocomial transmission as well as local transmission, where there was no history of travel or a nosocomial transmission. So, why did monkeypox emerge as a disease? Because it got just lucky that it entered into a population that had a lot of close contacts and intermingling. It was first the 2022 outbreak was related to the homosexuals and the gay population with a long-term intimate relationship. The increase in international travel makes the viruses easy to travel from one place to another, and the reduced immunity in circulation because those people who had a smallpox immunization in the past, that the number of circulating immunity within the population was declining, so it had a chance to re-emerge itself. This is not new. The transmission is with direct in contact with the lesions, contact with eyes, nose, mouth, or fomites, or like bed sheets or clothing. And short range droplet with a prolonged close contact. This is how it is transmitted. So the precautions that we need to take while isolating the patient within the hospital setting is contact and droplet precautions. Incubation and infectivity. So the incubation period ranges from 3 to 17 days. Most of the cases show up the symptoms within 10 to 12 days. There are two stages. First is the clinical symptoms, which is prodrome symptoms, where people come in with fatigue, flu-like symptoms, fever, fatigue, myalgias, followed by rash. Clinical symptoms usually last 7 to 14 days. And mostly, as I said earlier, the people tend to present within 10 to 12 days of exposure. Initially, when people manifest fever and other syndromes of viral infection, they are infective. They don't know, of course, they'll end up with monkeypox. The patient, the case remains infective till the lesions are completely healed and reepithelialization has taken place. So recently, towards the end of March and the early April, we just saw a spike in the number of cases. As you can see in the graph, from March 2025 to February, there were steady number of cases being reported. But all of a sudden, as we came into April, in the first week of April, the number of cases showed a spike. 7 newborns were diagnosed to have skin lesions, which were later confirmed as monkeypox from 2 facilities of Khairpur Hospital. Since then, many other places like Sakkar, Karachi, Islamabad has also reported sporadic cases here and there. So we just saw a big spike in the monkeypox cases, and this is the first time that we are in Pakistan that we are seeing a sustained local transmission without history of travel also. So now we'll just go through the clinical scenarios. So I'll just present 3 cases with diversified signs and symptoms to understand the wide variety of wide variety of presentations that it can cause. So our first case is a 20-year-old student who lives in a hostel with history of sore throat for 3 days, followed by a maculopapular rash. That started off from the trunk. It slowly involved the entire body. These are painless but itchy. So, what is your diagnosis? The rash, if you would see, the whole of the back is covered, and on a closer look, that's his closer look. So, what you can see here in a closer look of the rash is that you see rashes in different stages. You see pitting, umbilicated, you see vesicular, you see some scabbing also. So, what do you think would be the working diagnosis? Option A would be herpes, option B would be Mpox, C would be molluscum, D would be varicella zoster.
I guess it would be D.
Yeah, you're right. So the correct option is varicella zoster. So Mpox, if you'd see the difference, the differentiating clinical point in this, that in Mpox we see single crops and they are all in the same stages, whereas in varicella zoster we see lesions which are in different stages. Sorry. But the close differentials, as we discussed, were herpes zoster and molluscum varicella. So the difference, this slide actually presents a difference. So Mpox, varicella, herpes zoster, and molluscum. One is orthopox, other are herpes and the pox virus. Transmission pattern is different. In Mpox, the distribution of the rash is usually centrifugal, meaning that they would start from the face or limbs and then they would go towards the trunk. Whereas in varicella, trunk is predominantly affected and the peripheries are affected lesser. Herpes zoster is mostly a dermatomal pattern. It never crosses the midline. And molluscum is usually due to exposures. The difference in the rash of varicella and Mpox is that Mpox has a very deep-seated vesicular umbilicated rash. It is well circumscribed with a thick base. Whereas varicella is more of a vesicular rash, and we may see rashes in different stages of illness. Herpes zoster are small, thin vesicular rash. Molluscum is umbilicated for sure. So the rash of monkeypox is painful. Varicella is mostly itchy but not painful. Herpes zoster is extremely painful and it is mostly neuropathic. Molluscum again is non-painful. The way the monkeypox and the varicella start are quite similar. They both start off with fever, cough, coryza. But the differentiating factor is that in Mpox, you may go at regional lymph nodes. For example, if the respiratory tract infection is the predominant symptom, then you may get cervical lymph nodes. Or if the genital area is predominantly involved, we may get enlarged inguinal lymph nodes. However, in herpes zoster and molluscum, we do not have any constitutional signs and symptoms that we usually see in viruses. Again, Mpox crops are seen in the same stages, whereas in varicella, the crops of rash are seen in different stages. It is spread through Mpox, spread through close, intimate contact. Varicella is highly contagious. It doesn't. It's an airborne infection. It doesn't require long-term intimate exposure to disease. And the main differentiating point is Mpox is still quite rare in our society, whereas varicella is quite frequently, and we see frequent outbreaks during winter and spring season. Herpes zoster again is fairly common, and molluscum is common in certain age group. This slide actually shows the stages of the rashes that we see in Mpox. So the rash starts off as a macule, that is just changes in the skin color, followed by papule, which is a raised pump. Then it forms a vesicle. That means that it gets filled with fluid. This is the pustule form, which is kind of an umbilicated form, and where we may think of similarity to molluscum. And finally, it ends up with a scab. This is the stage when, after which, once the scabbing occurs and the reepithelialization occurs, then it is no longer infective. The common presentation that people present to us is the picture below, where you see a hand with distinct, well circumcised vesicular rashes. And they are all in the same stage. So let's move on to case number 2. So the next case is a 41-year-old male patient with complaints of it's a 41-year-old male patient with complaints of painful, itchy, umbilicated papules in the perineal region for the last 3 days. He had a history of fever, cough, weakness, and headache that started 3 days before the rash. He reported that he had protective or receptive anal intercourse with multiple partners 5 days before his complaints. He uses PrEP to prevent him from HIV, and his current status is non-reactive. However, he is on low dose of steroids for his ankylosing spondylitis. Inguinal lymph nodes were palpable with the following rash. So if you can see the rash, so this is basically his buttocks area, perineal area, where you see rashes. These are crops of vesicular, somewhat umbilicated lesions. So what do you think is the differential diagnosis? The options are A, anal warts, B, genital herpes, C, Mpox, D, pustular folliculitis. So anyone from the audience? All right. So in this case, the correct diagnosis is again Mpox. But how would you differentiate it from the other options? So in case of anal warts, they are more of a warty. You see a stalk, and they're more darker. In genital herpes, their lesions are small. They're not umbilicated, and they're fine vesicular regions. Mpox can be localized, and this is a case of Mpox seen in a gay man. And this is actually a true case. I took it from one of the publications from Turkey. D is pustular folliculitis, but the correct answer here is Mpox. So what are the next steps of management for this patient? First of all, we will confirm the diagnosis by taking a swab from the lesion and send it for PCR. We will isolate the patient ASAP and the isolation will continue until the rash completely heals with formation of a new layer of skin. He would be advised to avoid contact with persons who are at risk for severe disease. This constitutes the population which is immunized, and we'll discuss this further in the coming slides. Whenever in public, he should wear a face mask, take good care of his hygiene, and abstain from sexual activity until the rash heals. So in this population, there is a limited exposure, and this is a limited that the rash was only limited to the perineal region. It was not seen anywhere else. So this is also a presentation that we see in Mpox, especially in a certain class of people who and what advice would we give him for treatment? सबसे पहले तो you do not need to panic. Keep the lesions clean with soap and water. Keep it dry and uncovered unless and until he is moving out in public, when he should cover the rash. Seek medical care if the lesions become tender or show permanent discharge. Never and do not ever pop the blisters or scratch them, because they would delay the healing, and they would also leave scarring and marks. One should avoid shaving until the scabs are completely healed. Remember, it is a self-limiting illness, and mostly we prescribe medications for relief of symptoms that may include cough syrups, painkillers, NSAIDs, medicines for itching. Since his perineal area is involved, he may benefit from doing sitz bath. One should also take care of hydration and nutrition with high protein to boost the immunity and speed up the recovery. All right, now we'll see a very different spectrum of disease in case 3. This is a 40-year-old man who comes with history of high-grade fever, cough, and skin lesion. He has undergone a renal transplant a year ago and is on cyclosporin and low doses prednisolone for that. He had also received ATG, which is a very strong form of immunosuppression, few months back because of suspected graft rejection. When he came in, he looked very toxic. He had a borderline blood pressure with a heart rate of 90 beats per minute and a respiratory rate of 16 breaths per minute. A week back, he actually shared his room with a cousin who was visiting from UAE. His cousin was later reported to got sick towards the end of the trip and needed inpatient care. So on evaluation, this is what we saw when we saw him in the emergency room, and this was his HRCT, which we ordered it later. So what could be the differential diagnosis? So in a person who's highly immunosuppressed because of his history of immunosuppressions, current and in the past, this could very well be disseminated cryptococcus, because what you see in a CT scan are these small nodular lesions, and there's an involvement of the skin. So rightly so, disseminated cryptococcus is one of the differential diagnosis. It could actually be hemorrhagic complication of varicella. In immunosuppressed patients, we see an atypical presentation of varicella, and this could be one of the presentation this could be one of the presentations of the rash in varicella. Chickenpox pneumonia or varicella pneumonia is also quite common in immunosuppressed patients. Nocardiosis is another differential, which involves both skin and lung, and is quite often seen in immunosuppressed patients. Or it could have been a complicated monkeypox. Remember the epidemiology that he had shared a room with his cousin who had actually come from UAE directly to his house. So, keeping all these four differential in diagnosis, empiric treatment was started on these lines, and the relevant cultures were sent in cultures, and the swabs were sent in for PCR. However, it later was proved that it's a complicated Mpox. And this is an atypical presentation of Mpox in a immunosuppressed population. So who do we call high-risk population, and why do we call it? These are the high-risk group is the people who can have severe form of Mpox disease, because they have either because their immunity is too low, or sorry. So high-risk population, these are people who are at increased risk of getting severe disease. That include people like infants and young children who have no immunity whatsoever, pregnant female, the elderly at extremes of ages, essentially, and people who are severely immunocompromised, such as those who are on chemotherapeutic agents, who have received bone marrow transplants or any other form of solid organ or transplant. Also, people with history of atopic dermatitis or eczema, because the skin involvement, they may have um, complicated skin infections. What are the common complications that we see? This could be pneumonitis, encephalitis, infected skin lesions. It can also lead to sepsis and death. For the high-risk population, besides the symptomatic treatment and resuscitation, we also recommend using antiviral. This is tecovirimat. It can be used either alone, or there has been some studies that it should be combined with cidofovir for more effectiveness. But both these antivirals are not available in Pakistan. It is the treatment with antiviral is only recommended for a high risk group, or people who have severe disease, or who have a risk of severe disease, or those who present with complications. There's another strategy to prevent infections in high risk population, and is by giving through vaccines. So for nations in like Western Africa and Central Africa, where there are very frequent outbreaks, smallpox vaccine is actively being given to control the outbreak. Although the challenges with vaccine is that there are a limited number of vaccines available, and the population and it is not sufficient to vaccinate everybody. So they frequently use it to control the outbreaks. However, in countries like the US or the Europe, targeted vaccine is a strategy to give vaccines to people who are at high risk of developing infection, or in case of exposure, as a post-exposure prophylaxis vaccine can be given to a high-risk group. So there are two approaches to vaccine: either to curtail the outbreak, or in cases where there are not frequent outbreaks, a targeted population should be targeted for prevention. So coming to an end, to summarize this, Mpox is an emerging viral infection with an ongoing outbreak. Ongoing outbreak affected infants and neonates in Sindh, and if for those who may not have followed it, so essentially the outbreak started from two hospitals in the neonatal ward, and what had happened was that somehow the virus found its way into into the neonatal care, and one of the infants got infected by it. The incubator was infected. That same incubator was shared by the subsequent infants. So a series of cases were reported at one point in time, and this actually shows the critical lapses in the control practices at the hospitals. This outbreak could have been entirely avoidable. It can have Mpox can have a variable presentation, as we saw from systemic illness to pneumonia and genital to limited exposure to genital area. So it can have a variable presentation. You have to keep your um, uh, uh, you have to think of other differentials also when dealing with patients. Also keep epidemiology uh, 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 also consider the epidemiology when dealing with patients who have very low complications, and mortality is common in amongst high risk group, and this is much less common in chickenpox. Currently, we are seeing both the we are seeing far more chickenpox than we are seeing Mpox. Mpox is only limited to a cluster of people, whereas chickenpox currently we are seeing a outbreak within the city. So before stigmatizing that this is Mpox, I mean, we should consider all other possible diagnoses. And if the Mpox is amongst the differential and isolation, thank you. So with that, we come to an end.
Thank you so much. Thank you very much, Dr. Aisha. You've given an absolutely fantastic clinical overview, and you've really set the stage beautifully for the next session, which is really once we've suspected a case, now what do we do next? How do we test for it? And what do we test? So with that, moving on to the next two talks, we're now going to focus on the diagnostic pathway. And I'd like to introduce our first speaker, who will talk about the biosafety and real-world constraints and practical aspects of PCR and interpretation. We're going to have two speakers in this session. So the first speaker, Professor Saeed Khan, who is currently serving as the Director of the Provincial Public Health Laboratory, Sindh, and who is also Professor of Molecular Pathology at Dow University of Health Sciences. He has continued to play a pivotal role in Pakistan's national health security. He is also currently serving as the president of the Association of Molecular Pathology, and also he is the General Secretary of the Association of Biosafety in Pakistan. So over to you, Dr. Saeed. Dr. Said, we can't hear you. Is your mic on?
Can you hear me now?
Yes,
Am
thank
I
you so much. Yes.
okay? I'm just trying to fix the slide first. Okay. Thank you, Dr. Natasha, for the generous introduction, and I'm thankful to the previous speaker, Dr. Aisha, who just explained everything, and things are much easier for me now. I will share a little bit story because while you are diagnosing disease based on the symptoms, you need a very expert person to identify. If you do this without uh, experience and depth, you may misguide or you may misdiagnose, and that may lead to severe consequences, which had happened this in the case of Mpox and sin. If you have witnessed some of the notification from the government that there's a disease called staphylococcal scalded skin syndrome, uh, and later on we received suspected sample for chickenpox. When we tested those sample in the lab, those were negative for chickenpox. But when I just checked it for Mpox, those were came positive for Mpox. So just look at this story from SSSS, then chickenpox, those were negative. Ultimately, in the lab, they were proven to be Mpox positive. So there must be a combination of different fields like clinician, physicians, and the laboratory diagnosis is equally important. And there must be coordination, because if they were having some issue, I think if you have heard this news that these symptomatic patients were appearing and the clinics from the beginning of the March. Even we witnessed when we were visiting these areas, we were told that such cases were coming even in February. So all those cases were misdiagnosed or mislead, which led to this outbreak. Coming to the topic that I have given, the Mpox sample collection, transportation, and delivering to the lab. The safety come first, as this is very, I think, serious disease. So while dealing with the sample, we must make sure that we should not aggravate the situation further. So we should protect ourselves, and this biosafety mean to keep ourselves and the environment safe from the bugs. In this case, we are talking about Mpox. And similarly, we should also stay the bad people away from this bad bug, so they should not misuse it, because this is a very serious infection and disease and can be misused by bad people for the biosecurity purposes. So both are very much important. And combination of both biosafety, biosecurity, we call it bio-risk management. We need knowledge, practices, equipments, combination of both, and then we can reduce the risk and we can deal with the sample. As I have a short of time, so I'll be quick. This slide, I think, very much important to break the chain of the transmission. People have different opinion. They have knowledge based on the book information, but some of the reality on ground, sometimes they behave differently, aiding the local environment and local situations. Sometimes new phenomena occurs. So new mode of transmission sometime arises. So we need to keep that in eye as well. People usually link Mpox as a sexually transmitted disease, but in this case, when we saw a 7 days old baby, she was infected with Mpox. So, and then we checked the parents; they were negative. We were surprised that what were the transmission. There was no vertical transmission there and no sexual. So what is the reason? Then we dig out and reach to that incubator that the Dr. Aisha mentioned, and we identified that incubator basically somehow vertical transmission baby came to that incubator. That baby infect that incubator and follow up babies. They came to that incubator and they kept on infecting. So the source of transmission was that incubator, or currently we are checking different other hospitals preemptively that environmental sample that we are collecting, so that we should change the break. We should break the chain of the transmission of the infection. Otherwise, if we are just finding out positive patient, diagnosing them, that will not serve the purpose. The mode of the transmission and the source of the transmission should be identified and they should be removed. Otherwise, we will be adding more to the this continue outbreaks. I think this slide been discussed, the different transmission routes. One of that is hospital-acquired infection. That is, we should consider is currently one of the biggest source. Is not the sexual transmission, rather it is the hospital-acquired, or the currently in the case of the babies, these are those incubators which are making the issue more serious. This slide again, I won't spend more time. For the sample collection, I will pay a little bit attention to this because being in the lab a person, I would be more interested that I should get maximum viral load in my sample. So I should not miss the sample as false negative sample. So that is my interest, that where should, what would be the time that I should get collect the sample, and when I have the patient, from where I should collect the sample, should so that I can perform my test and I can get the best result. If it is positive, the patient is true positive, it should come true positive, and if it is the patient is negative, should come negative. So I will be more interested in the lesion in this case. If the patient have lesion on the skin, so most ideal sample would be the skin lesion, and I will take sample from here. Otherwise, I can go for oropharyngeal sample as well, but the best sample would be the lesion because it's the maximum virus load is there, viral load is there. So when to test the sample has been discussed already, but I will explain a little bit more that if someone has current active infection with symptoms, most probably this is the right time that we should collect the sample. And if it is, we have rashes on the skin, so we can for sure get the sample collected from those lesions. Sometimes we are too early or too late. So in that case, blood may be helpful to trace if there is any virus over there, or it is a DNA virus. So maybe we can get some DNA. In this case, we also got blood sample, and we found the virus over there as well. So the risk population based on environment and situation. In current cases, the babies who've been visited those contaminated incubators or equipments, if they are coming to contact with other babies or even adults, there was reverse transmission as well. That's a new phenomena that I observed. Usually we have vertical transmission from mother to child, and here we observe the mother being infected reversely from child to mother transmission. So that is also a new phenomena for me, at least I have observed. For the PPs that are required that we need to protect our portal of entries, and so we should use gown particularly to protect our bodies, then gloves, eye protection, because the droplets can go in through eyes, respiratory tract can be protected by N95 mask ideally. And the proper documentation is very much important. If we have collect the sample, we don't have proper information, again, it will be useless to trace then the contact tracing in where the patient came from, which area he collected, he got this infection. So the patient information is very much important. We recommend usually to first fill the form and then collect the sample. These are some of the official form that we have for these patients. So these information must be provided along with the sample. And currently we are facing some issues because these areas, they don't have proper kits available. So we have ideal situation and we have real situation. So and in the field and real situation, they don't have ETMs available, they don't have proper kits available. So then we learned this in our biosafety, biosecurity training. I will appreciate my mentor, Sean Kaufman. He just gave us an example that it depend in risk assessment. Based on the risk assessment, there is no ideal situation, but there is safe situation. You can create a safer situation in the available circumstances. So VTM, that is the blood collection kit that is recommended, but if it is not available, we can use the synthetic swab and plain tube for the safety and keeping that container safe. We can use the triple packaging for transportation. Labeling is very much important, and we must label that which sample is coming from which patient and from which part of the patient. Like we may have different samples from one patient, so we must label it if it is a lesion, one lesion or second lesion, or it is from oropharyngeal swab, it is a blood swab, so that must be labeled properly. The collection should be done properly. We must protect ourselves first. We should guide the patient and counsel the patient that how we will be collecting the sample. So we should also, if it is adult, we should get the consent from the patient. If the baby, so we should talk to the parents as well. In avoiding any sharp, we must avoid any sharp. I have seen some literature that they were recommending that there must be some scalpel must be used or needle. So it is not recommended, it should not be used. Simply we should touch the swab with the lesion, and a lot of material will come with that swab. So that is more than enough. We should not use any scalpel or any needle. It is not required. Then the preferred sample is, as I mentioned, is the skin lesion is on the top, vesical pustule, lesion root, and cross. These are the sample. Better to get more sample from one patient if it is available. You have require resources and you have like more lesions, so it will increase the chances of better results. As I mentioned, the more the viral load in the sample, better the chances to get the result done in the PCR in the lab. So the alternative specimen, as I mentioned, ideally is the lesion, but oropharyngeal swab can also be helpful if sometime we don't have lesion there on the patient and we suspect the patient is close contact with a positive patient. Then saliva, rectal swab, whole blood, or lastly urine. But the ideal would be first the lesion and then the oropharyngeal swab. The Mpox is a category B infectious material, so we need to properly package. That means in available circumstances, at least we should tightly pack the tube, put some absorbent, and keep it in a zip bag, and put it in another bag, and then another container with some ice or ice pack. And that should, in current cases, we are talking about areas like Khairpur or Sakkar. So it is a remote area because the sample is usually transported to Karachi and then it is performed over there. So we need to make sure the sample is properly packed. It should not spill over. And stability of the material should be there. And luckily, in case of diagnosis, the DNA virus is a bit stable, but still we should make sure the biosafety and biosecurity of the sample. The transportation should be done ideally if it is kept at 2 to 8 degree. It would be good to be tested in the lab. So this is just a repetition of the same thing, that the sample need to be properly packed, packaged, and transported. Again, this is the cartoon through which I am just emphasizing how the sample need to be collected, transported, and the PPEs, the list of the PPEs that are required, the documentation of the patient, and properly transportation to the concerned laboratory. The transmission route, which has been discussed, we need to protect those portal of entries, and the standard contact for that, we need a proper PPEs, like to prevent the droplets, the N95 mask. Sometimes aerosol being generated in different situations. So we need to focus that as well, that we need to prevent that those droplets and aerosol into the body. And say specimen collection, we need to make sure we should not generate any aerosol. We should not use the sharp. Otherwise, the virus may spread further. And if there's any exposure, someone think that has exposure, then they should properly seek the expert physician and doctor for follow-up. Then common gaps that we have observed that currently people are doing that, the healthcare workers, they are touching the bedding and towels and clothing frequently without PPE. So that may lead to like severe consequences, especially if you think the patient is not Mpox positive, some other pathogen. So the shaking lines or dry dusting will increase the aerosol generation. So that need to be avoided. Then the diagnosis mimicry, that again, as I mentioned, that people may think that is a different other pathogen or viruses. So that may mislead for diagnosis as well as increase the exposure, because for that they take less PPEs. In here, as I mentioned, that they were expecting that it is staphylococcal scarlet skin syndrome, so they were not adopting any proper PPEs for that, and ultimately it was Mpox. So waste management, that is very crucial aspect, that waste that being generated either in the clinic or in the laboratory, it must be properly incinerated or autoclave. And we should clean the environment. As I mentioned, currently we are collecting different samples from the clinical environment, and we are getting positive results and we are then advising the health authorities that they should disinfect those areas. The discipline of the doping of the PP is very much important, even especially for the physician and expert doctors. They do these mistakes where when they get done from the patient, they are usually in a hurry and run, and they remove the PPs in wrong order, and they may infect themselves. So we should follow the proper sequence and rules of the doping as well. So the Mpox limited resources, as I mentioned, currently the collection of the sample without VTMs or proper PPEs, that is a challenge. So we've been there in those area. We train those people that how we can replace ideal situation with the real situation, still safer. So that need to be done. In case of VTM, we replace them with the dry swab method. They were having the red top tube available, so you can use that sterile red top plain tube for keeping the sterile swab collected sample being collected, and then cleaning the environment with 0.5% chlorine solution for environmental. Similarly, the laundry need to be properly clean, and vaccination is also available, one option in the high risk population, or especially the healthcare workers. I won't skip this slide. Protection from monkeypox, we need to protect ourselves first, and then protect others, and then environment. And we can do this by knowledge that we have, how the Mpox can spread. Then we need to have tools or equipments available like PPEs, and then practices. The behavior is must and required, that if we have the knowledge, we have the PPEs available, we have the resources available. If the behavior is not good, then we may still be spreading this virus and putting ourselves as well as other on risk. So behavior is the top recommendation that I am suggesting, and also I suggest over there with while I was meeting with the high authorities, that sometimes we are complaining that we don't have resources, but the behavior, like we don't practice good practices. So gloves are there, masks are there, but they are not wearing on time, or not they are not wearing or doping in a good sequence. So that is need to be corrected or practiced as well. So the key collection sites is the face, the lesion, the face, mouth, and the throat, and that been discussed already. So these are some of the pictures that from my visit that I have been there twice to Sakkar and Khairpur and other affected areas. We witness these patients and talk to the high authorities. We train people and try to change the behavior. So far we are getting good results, but the spread that already been done, we are getting those sample. But luckily, the source that was spreading these infection is a cohort and is epicenter that been removed, or that me initially was sealed, now been disinfected, and we are collecting sample from there. Once we get a green signal, we will allow them, they can open it. These are the high authorities, the Commissioner of Sakkar, Deputy Commissioner of Khairpur and Lalkhana, the other high official from the Federal Ministry of Health, from NIH, and from DG Office of Health. Luckily, we were lucky to interact with all these people and was part of the team from the federal and the provincial health officials. We witnessed and visited these places, and we identify the gaps and give our recommendation. The risk communication is a key aspect while dealing with any outbreaks. So having the knowledge and spreading the knowledge, that is very much important. How we can protect the bigger outbreak while we already have this outbreak, but it can be converted even bigger like COVID if we don't take action on right time, and we can't do that without the involvement of the community. So we should, there must be a three-way communications, the communication that we are having with our health authority and the official and the experts, and then the communication that we can have with the media, and the communication that we can have with the masses. So all three sector can be different and separated, but the objective would be the same, that we should be able to prevent the further spread of this infection. So the main summary from my side would be right detection at the right time, then protect. While detecting or collecting the sample, we should protect ourselves in the environment, and then collect the maximum sample. Maximum mean the maximum possible sample where the virus is there. We should touch that area. And then once we collect the sample, we should clean all that we have contaminated in terms of waste being generated that need to be properly disposed of, and we should follow the SOPs of biosafety and biosecurity. So that's from my side, and I usually end with these words that no one is safe until everyone is safe. So we should contribute to achieve this slogan. Thank you very much.
Thank you so much, Dr. Said, for that extremely important, comprehensive, and thank you so much for sharing great, advice on sampling and also transporting these specimens, and for sharing your experience of being in Khairpur. I think that's really, really, really helped. Thank you so much. It was fantastic.
Thank you.
So I now I'm going to move on, because now we're moving now from the sampling the patient and doing it safely to now getting that sample to the lab, and moving on from trying to understand what we're going to do with this sample, how it's going to be tested, and then sort of the details on the molecular testing for Mpox. So I'm inviting our second speaker for the diagnostic pathway segment, and Dr. Zara Hassan. She is professor and consultant in the section of molecular pathology in the Department of Pathology and Laboratory Medicine at the Aga Khan University Hospital. She studies host pathogen aspects of infectious diseases. And really, to me, honestly, she's really been at the forefront of providing timely diagnostics and we saw that happen during COVID. And again, a tremendous amount of work subsequent to that she's been doing. So Dr. Zara, over to you.
Assalamu alaikum. Thank you, everyone, for this opportunity to present. Thank you, Natasha, for the introduction. I'll be happy to start if I can share my slides. And the seminar has already introduced us to the signs and symptoms of individuals who can be suspected for Mpox. And Dr. Said has very nicely explained how the sample can be collected. I will now add the piece about the lab and explain how, once we have the sample, how do we, in context of the samples that we have, how we best place to test it, and what does that tell us? Now, it's already been, I'll just go to slideshow. Okay, you can see my slides. We are here because particularly there's an outbreak right now, and it has been explained to us that the Mpox is not new, but just to place it once again in terms of how the transmission occurs, the first zoonotic transmission was identified from monkeys. That was in the 1950s. And since then, the monkeypox, now called Mpox, has been endemic in the African continent mostly. And it's been in Central Africa and also in West Africa. There was a big spread in 2022 with the public health emergency in 2022, and then also in 2023. We know that the transmission now is beyond spread through monkeys. There are other animals that can be reservoirs for the virus, which include rodents and mice and squirrels. And then there's human-to-human transmission, there's vertical transmission, and it can be through respiratory routes as well. It's important to keep in mind that most of the cases that have been reported since 2026 have been associated with clade 1 strains. So there's Mpox, clade 1 and clade 2 strains. And in the last 12 months, a very high number of deaths have been reported from Africa, which is 158 deaths. Pakistan is yet not listed amongst on the WHO outbreak website. Perhaps it takes a while for the data to be made available. But here's a picture from one of the cases that has been highlighted from Pakistan, from the Khairpur case. And as you can see, it looks pretty much like the cases of Mpox identified from Africa recently. Now, what do we need to know about the virus so that we can understand the best way to diagnose it? So rapid diagnosis is done through amplification of nuclear DNA in this case. It's a DNA virus. And in any virus, there will be regions that are conserved. That means they don't change between viruses. And then there'll be regions that are variable. Okay, and the variable regions are the ones that are used to differentiate between strains, and these variations are helpful in identifying species, in identifying genetic differences. So, for example, in outbreak tracing, it'll be important to try and understand variations in regions like this that would differentiate between clade 1 and clade 2 viruses. So central to just direct detection for PCR, the DNA polymerase gene is a target. There are envelope proteins that are also targets, and all of these are developed into assays that allow amplification of the target region and can be used to identify the presence of Mpox virus. And it's very important to have these PCRs, because as we saw with the case presentation, you can have pustules or rashes that may need to be differentiated between Mpox or varicella infection or something else. What I want to put up here is that we know that the case fatality rate between clade 1 and clade 2 are quite different. So the clade 1 has a CFR of 5 to 8%, while the clade 2 is much lower, less than 0.2%. And the outbreaks which were in 2024 and which was found, to spread in Europe as well and in the US was clade 2. And we need to know what is spreading right now. But this is just a slide to show you that genetic differences occur between clade 1 and clade 2 strains, and also they circulate differently. This is some data from, just to give you an idea about in the African continent, which is endemic for Mpox. Clade 1 and clade 2 are both present, but clade 1 is more common, has been more common in Central Africa, while clade 2 in West Africa. The slide on the right tells us, this is again WHO stats, indicating that there is a spread of clade 1 strains globally that has emerged from Congo, but is continuing to spread. The NIH, there have been a lot of questions about testing algorithms, where to go for testing, and information is available in the revised national guidelines for Mpox. These were NIH guidelines made available in 2024. They're very thorough. They actually give a lot of resource information about the kind of PCR tests that would be useful for diagnosis. They also provide information regarding contacts for provincial labs. So we heard from Dr. Said Khan, who's the contact person for Sindh. But since people have been asking about where to go to for testing in other parts of Pakistan, that information is available. So please do look up the national guidelines for Mpox. I'll loop back to sample collection and what sample is the appropriate sample to be used and put towards extraction of DNA for the PCR. As mentioned by Dr. Said, the samples can be skin lesions, they can be exudate, they need to be collected with a swab. It's important to be aware that the viral load varies depending on the lesion that you swab. So lesions, if you collect a swab from something that has an exudate, you will have more material available. If you collect a swab, a scab, and you put that separately. So first of all, the exudate swab and the scab swab need to be separated. They need to be in separate tubes, not mixed when you send them. The scab is likely to have a lot more virus, okay? And this then becomes important when managing the specimen in the lab, because the biosafety considerations for diagnostic testing need to recognize that the virus needs to be, until it is lysed, it is a very infectious specimen. Clade 1, Mpox, is a select agent. Sample processing should be done in a biosafety level 2 hood. If you have an exudate that has come from a swab that is then in VTM, or a dry swab that is then, put into VTM, and that suspension is used for DNA extraction through a kit, that can be processed directly. But lesions need to actually be broken down through a mechanical method. They need to be lysed with vigorous mixing. This process will generate aerosol and should be done inside the hood. So important to be aware of that. Now, once your extract from your lesion or your exudate is ready, then you can extract DNA using a kit or manual method. PCR testing is fortunately available across Pakistan. So both public sector labs and us at the AKUH are providing PCR testing. Again, primer and probes kits are available for them. Where a kit is not available, one can use a primer and probe directly to the core region of the Mpox virus. And the principle for PCR and probe applies, that basically your targets would bind the DNA of the Mpox virus, your probe would be amplified through every cycle, and the PCR machines allow us to see the amplification of the PCR product if the target is present. So the way the PCRs are developed, there's always an internal control which will tell us if the sample extraction is correct, because you need to make sure that even in a negative sample, you need to have a robust way of diagnosing or identifying that your controls have worked. And a positive sample in this particular assay, and I'm not naming the kit because there are many kits that are available if you're using them, as long as they've been validated and they are approved for testing, they are all efficient and they are good. Mpox sample will identify more than one viral target in addition to the internal control. So that's how we identify a positive test in the laboratory. So finally, how do you report the test? The first part was identifying where the sample has been taken from and who the sample has been taken from, as well as what the site was, okay? Once you have a result, then the laboratory report can be given after verification, and as part of the requirements of the NIH guidelines and health department guidelines, it's important to report each positive case to the health department, the provincial health department, who then reports to NIH. Ethics of the testing is extremely important. Confidentiality is essential. And unfortunately, this is something that often can be lapsed. So it is important that when discussing your patients as well and where samples have been collected from, it's important to protect the patients so that this can be done in the most sincere manner, because the patients are vulnerable, and it is at the end of the day the patient's responsibility to make sure that the testing is done safely and that the results are given to the patient as well as the authorities, so that an efficient public health response can be rolled out. One final point regarding considerations for testing. While we've mentioned that it is an advantage to take more than one swab or to collect different samples, at the level of testing, there is a limit to the number of tests that can be done. So please use your clinical judgment in deciding how many swabs to be collected from different sites, whether you need 2 or you need 3, and what is the most appropriate sample, because there's a limit to the number of tests that can be done, because PCR is, after all, expensive. And then also the second question is, do you need to test for every patient in a given cluster if once Mpox has been identified? So that question is not for us in the lab. It is for discussion perhaps later on. How many individuals in a cluster need to be tested if you have limited resources? And then really important to collect the samples as soon as possible and submit them to the laboratory at the conditions that we've been told about, that they must be, that a cold chain needs to be maintained, and the samples need to be wrapped properly. They need to be double packed so that they are not infectious. So finally, I summarize this by saying that the PCR is a very rapid and adaptable assay that is sensitive. It can detect down to about 100 or so viral copies. It is specific, so it will help differentiate between Mpox and varicella. But key to effective PCR diagnosis is the sample. Correct sample collection, correct sample transport, appropriate processing, because, if we have a scab and it's not been correctly processed and the virus has not been extracted from it, then you will end up with a false negative. Clinical and laboratory based, I think Dr. Seema, who comes next after me, will talk more about IPC and clinical waste management. But it's really important to be aware that all samples that have been used for sample extractions and the waste that has been created needs to be disposed appropriately. And then, of course, confidentiality of results is extremely important. So I'll end here. Thank you.
Thank you so much, Dr. Zara. That was fantastic. I think you've walked us through the nitty-gritty of what goes on in the lab and how crucial it is that really the quality and the nature of the sampling really is the key step that's going to determine how good a result and how accurate results will be obtained. So it's not just about testing. It's also, I think you highlighted a number of really important things, which is to test responsibly. Responsibly not only in terms of the resources that are available, but also responsibly in terms of our duty to the patient. So, our duty is to protect the patient, but also the wider community. And that often leads to some, we've seen that with COVID, but when we come to the discussion and Q&A, we can expand on that. So moving quickly to the last part, but not the least important, I think perhaps the most critical, again, aspect, of this seminar is that once you've confirmed a case, how are you going to ensure that you prevent it from spreading? Anne, who is Professor of Microbiology in the Department of Pathology and Laboratory Medicine at the Aga Khan University. She is also Vice Chair of DIFI, the Department of Infection Prevention and Hospital Epidemiology, and Chair of the Sterilization, Disinfection and Environmental Subcommittee. She's also a member of the National Consultative Group for IPC at the CDC NIH Islam. Dr. Seema, over to you. Thank you. Oops, why not? I think मेरा बंद हो गया.
Assalamu alaikum. Am I audible? Hello.
Ji, Dr. Seema, we
Yes,
can hear you.
Dr.
Thank
Seema.
you.
I cannot open my
Thank you.
camera. Okay. So I cannot open my camera. It's saying that host has stopped it. Please, can you allow my camera to get open?
Gee, we're just sorting that out, Dr. Seema. Just a few seconds.
I haven't
Lukman is
stopped
looking
your
into it.
camera. Dr. Said, would you stop your screen sharing? Now, Dr. Seema, you may try it again.
No, I don't think. Can you see my screen? Yes. Okay, I think I should start. First of all, thank you, MMIDSP, especially Sumaya, for this talk. And I would also like to thank Natasha for kind introduction. So the topic, as you have already mentioned, that it's infection prevention and control for Mpox. So obviously, we have seen so many outbreaks in different healthcare setting of Pakistan, not just Mpox, but also a different kind of other infectious diseases like HIV and so on. You can name. So it is very important topic. So I would. Okay, so in my talk, I would be covering following IC areas, like what to do once Mpox is suspected in a patient, what kind of isolation precautions, PPE and transmission-based precautions should be taken for these patients, and how could we protect high-risk areas, for example, NICU, oncology, transplant units from Mpox, and what a center should plan to handle an upsurge of Mpox patient coming from the community, and how to handle a deceased Mpox patient. And I've also added some infection control precautions related with the home-based care, but if I will get some time, then I will mention that. And finally, 3 take-home messages. So first, let's see what to do once Mpox patient has come to your hospital or any setting. So mostly these kind of patients, they are presented in the emergency room. Either they may contact a physician in the outpatient department, outpatient clinics, and you can see these patients involved as well. So it is very difficult to maintain a distance of at least 1 meter while working in so much busy areas like emergency department and outpatient clinic. So it is advisable to routine use of medical mask by healthcare workers. So because it is a part of standard precaution, because you are maintaining yourself protected from infectious droplets releasing from the patient while talking, coughing, sneezing. And immediately, if you find these kind of patient, if feasible, shift the patient in a separate room for examination, and ask patient, or if the patient is a child, then caregiver to cover the lesions immediately and provide, if medical masks are there, then provide that to the patient, or if a patient is adult. And there should be hand hygiene apparatus should be there, and also patient should be asked to follow the cough etiquette, at least use their sleeves while sneezing, coughing. What are the PPE that should be used during examination? That will be based on risk assessment. While working in different units, ideally these PPE should be available. And while examining the patient, a healthcare worker should wear a gown, gloves. A person should use eye protection in the form of goggles or face shield, and the medical mask. In case of any suspicion of airborne transmission, you can also go for using N95 mask and other kind of respirator. If the instructions after examination and screening, same precautions should be followed during transportation of the patient to other areas, for example, to the ward and X-ray setting. After examining the patient, perform complete disinfection of the instruments and the area as per protocol of cleaning and disinfection, and make sure that housekeeping, who is doing the disinfection and cleaning of the area, that should be using personal protective equipment while dealing the area. At the same time, during the initial patient handling, some healthcare worker might get exposed. So you should identify those healthcare workers, and then obviously these healthcare workers should be notified to the infection control team so that they can be managed appropriately. Finally, the testing, if there's a need of testing and you have already organized the testing protocol, then testing sampling can be performed from the patient, and similarly, notification to the infection control team should be done at the same time. I will talk later about the vaccination protocols. It depends upon how your center is prepared for the pre-exposure or post-exposure vaccination. So far, it is not available in Pakistan, but maybe we can talk about it so that these vaccines can be available, especially for the high-risk persons and healthcare workers. A screening protocol that is used, that is well defined by the WHO, and the patient can be classified according to that screening protocol into a suspected case, probable case, and confirmed case. And as per WHO criteria, suspected case is a case that person of any age who has presented with unexplained rash, acute rash, and one or more of the symptoms like fever, headache, swollen lymph nodes, muscle ache. And a probable case is that case that is a suspected case that has, along with the initial sign and symptoms and rash, they have some epidemiological link with the confirmed case within the last 21 days, travel history endemic to the endemic area, multiple or different type of sexual partners in the last 21 days before the appearance of symptoms, and possible result of any other orthomyxovirus blood test, but not Mpox. A confirmed case is that case that meets the clinical definition and is laboratory confirmed for the virus using PCR or DNA sequencing. And a discarded case is that any suspected or probable case that has negative testing by PCR or sequencing. So based on these criteria, patient you can perform the screening, and then the finally isolation and the PPE and transmission-based precaution can be followed. So what to do for the patient placement and PPE? Immediately isolate patient in a single room. Even if you have just a suspicion, you don't have to you don't have to take time, and you have to shift the patient immediately into a single room. And ideally, because most of the patient, if they are clinically stable, they don't need a critical care setting, they are not undergoing aerosol generating procedure. So in case of that case, just droplet precautions and contact precautions are required, and room should not have any special ventilation system. But of course, if a person is you are saying that a person is quite sick, or the child is very sick, then obviously there is need of some special arrangement of different ventilatory requirement would be there, and the patient may be needing aerosol generating procedure. Then the airborne isolation room would be required in that scenario. In case of non-availability of single room, for example, if you are working in a government setting or very resource limited setting, because in some setting we don't have like single room available. So if a patient is stable, preferably single room isolation is still needed. But if there is non-availability, then you can keep the patient on the corner bed, and you can cordon off the area, and distance from the other patient can be maintained, keeping the beds at least 1 meter away from each other. And you can draw a privacy curtain to keep the patient privacy. And you should ask the patient to cover any wound or any lesions that is present on the patient's body. As I have already mentioned that airborne precaution and isolation rooms are needed in case of aerosol generating procedure. And in some cases, on the initial suspicion, you cannot rule out other differential diagnoses like chickenpox and measles. So even in those scenarios, airborne isolation is generally recommended. So for contact and droplet precautions, all health and care workers providing direct, even if they are providing indirect care, like those persons belonging to housekeeping department, personnel coming from the linen and laundry department, all of those persons who are entering the patient area, they should use contact and droplet precautions. And according to risk assessment, gowns, gloves, eye protection, medical mask should be used. And if you think that room ventilation is poor or unknown, and the aerosol generating procedure is being performed, patient is immunocompromised, or if the patient is showing mucosal lesions, continuously coughing, sneezing, then you can even go for use of N95 mask or another kind of respirator if they are available. Patient should, as I've already mentioned, they should be asked to cover their lesions, as well as they should use medical mask if they tolerate. Personal hand hygiene and cough etiquette should be instructed to the patient and caregiver. Decontamination of reusable patient equipment is very important. Waste management is very important, because these are the areas that are easily overlooked. And for example, if we talk about the equipment and instrument management, always try to use disposable patient care item. If, for example, thermometer, and that can easily be used and disposed of. But some items cannot be easily be disposed. Then the dedicated item should be given to the Mpox patient till patient hospital stay. And if these items are during the patient stay, as well as after the discharge of the patient, if they are going to be used on other patient, these items should be clean and disinfected before being used on other patients. And cleaning and decontamination protocol should be according to guidelines, and it should be according to manufacturer recommendation. If there is no manufacturer recommendation, it should be according to international or national guidelines. Similarly, infectious waste that include body fluid and solid waste of Mpox patient should be handled and treated as infectious. They should be kept while utilizing appropriate PPE by the housekeeping department. They should be disposed of from the patient room and transported, and then easily and safely incinerated, and according to local policy or hospital policy, if incinerator is not available, then they can be transferred to other facility for the incineration or burial. Environmental cleaning and disinfection protocol should be strictly followed, because we have seen that lack of the environmental cleaning and disinfection protocols can lead to survival of these pox virus into the environment, and then it can transmit it to the other patients easily. So more frequent cleaning and disinfection should be performed on frequently touched surfaces, including doorknobs, bed rail, bells, different incubators and other respiratory therapy equipment, monitors, stethoscopes, patient files, and frequency should be at least twice daily. Disinfection should be done. Plus, if there is any spillage or or there is a visibly contaminated surface, it should be disinfected immediately. And what should be the cleaning protocol? First off, you should instruct housekeeping, and they should be properly trained for doing that. And proper training protocols should be developed for the housekeeping keeping personnel and wardens who are dealing with these disinfection disinfection management. So first to clean the surface with the end of equipment and the surface with the soap and water, and then disinfect with the help of appropriate chemical disinfectant. For example, if it is very simple to use alcohol based disinfectants or the hypochlorite based disinfectant in the healthcare setting, but it is important to remember that these disinfectants should be allowed untouched on these surfaces for at least 1 minute to act properly, so that virus would be killed by these disinfectants. And this should be communicated, and properly healthcare workers should be properly trained for that. How to handle and transport patient used linen? Because we all know that Mpox can be transmitted by spread of contact of lesions with the linen easily. So these used linen, when they are handled by a healthcare worker or a laundry personnel, they should always wear appropriate personal protective equipment while sorting out these soiled linens, and they should handle these soiled linen very carefully. Minimal manipulation and agitation should be done, and these linen should be placed appropriately and carefully into a designated bag or container, and then transported to the laundry. And in the laundry, appropriate decontamination protocol should be developed, and that can be in the form of manual or machine wash. And WHO recommends that either you can use hot water of about 70 degrees centigrade, or you can use a combination of hot water along with the detergent, or you can even go for hot water that is mixed with the low concentration of sodium hypochlorite solution. And duration for disinfection should be given of around 20 minutes wash. If a healthcare worker get exposed to Mpox, what to do? You should first identify that what is a significant exposure. So significant exposure in case of occupational setting is unprotected contact with the infected Mpox patient, including their body fluids, lesions, or contaminated material. So if you have identified a person has reported that a healthcare worker has been exposed, that person should immediately notify this exposure to the infection control team or the occupational health team. And then these teams would evaluate that significant exposure has been occurred, and if it has been occurred, then these persons would be monitored for surveillance for the future for any symptoms. And strict surveillance of these persons would be required for at least about 21 days. So if a healthcare worker remains asymptomatic, so there is no need to exclude that person from the work. yes, it is important that these persons, if they are working in a patient critical care areas, in a immunocompromised setting, they should be moved from those areas to some other place, because they will be dealing with the vulnerable patient, and asymptomatic infection can occur, and this person can become a source of transmission of Mpox to these vulnerable patient. If during the surveillance, if that healthcare worker becomes symptomatic, obviously that person then be excluded from the work till all the lesions become crusted, and healthy skin will be visible, and person become asymptomatic. What a center should plan to handle Mpox patients. So it is very important. Recently, we have also received a notification from the government that prepare yourself, your setting to deal with the influx of possible influx of Mpox patient. So it is very important for all the centers to get prepared for this kind of situation, and the main responsibility of preparedness would go for higher administration, and they should support not inventory support, logistic support, and also a different other kind of support to the infection control team. And infection control team should take the lead for the preparedness, and they should do first the education and awareness of healthcare workers, and they can improve the knowledge of the healthcare worker by using webinars, CME, by using signage, by using flyers. So once your healthcare worker will get appropriate knowledge, then at the same time these healthcare workers should undergo training for the use of standard and transmission-based precaution, for the use of different personal protective equipment, and especially donning and doffing, and handling of soiled equipment, linen, and waste. So it is very important. Besides that, there are other important aspect of preparedness that included in the administrative control of Mpox, as well as engineering control. If I talk about the engineering control, engineers should work hard with the IC team for the availability and appropriate working of isolation room, airborne isolation rooms, then the anti-room, availability of anti-room, safety cabinets in the laboratory setting, and triage area. Regarding the administrative control, so it would include to work for the screening and triage of those patients. Most of the time, screening and triage is done at the point of entry to the healthcare setting, and signage should be posted. Instruction should be put on those areas, and healthcare workers should be trained for screening. And for example, healthcare workers desks should be prepared in the emergency department, different clinics, and we can take the example of COVID, where the different hospitals they did the preparedness for the screening. Same protocol can be applied over here for the screening of Mpox, and a simplified questionnaire can be developed, and it could be just computerized, or in a low resource setting it could be just by doing questions to the patient, verbal questions to the patient. And screening staff should make sure that they should be using personal PPE, at least medical mask. They should maintain a distance, and they should refer to the triage area. for the level of care of patient, which type of level of care of patient patient care is required, and if the patient needs critical care unit, patient should be shifted to the critical care unit, high dependency unit, to the ward, NICU. Administrative control would also
Dr. Seema,
include.
sorry
Yes.
to, I really apologize for interrupting. I'm so sorry. I just wanted to let you know it's 12:40. We're a little
Okay.
over our time. I apologize. This is very important information. But I was just wondering how many more slides you had so that we could, there are lots of questions for you as well, actually. That's why.
Yeah, okay. So I would try to just close my talk in a few minutes. So then administrative control would also include different availability of PPE, maintenance of inventory, maintenance of patient confidentiality, communication to the media, government, and high risk areas. Again, I would say that in the high risk areas, for example, NICU, all the baseline is that you have to make a strict protocol for infection prevention and control, so that cross transmission between the patient cannot take place. Strict surveillance and screening of the healthcare worker, visitors should be done. Vaccine, if they are available, that can be given to the high risk area healthcare workers. And then obviously, three key take-home messages regarding my talk is that don't wait to isolate. Immediately isolate the patient, even if you are just suspecting a case as an Mpox case. And protect high-risk units using strict IC protocols that not just the isolation of the patient, but also appropriate cleaning and disinfection protocol, screening protocol, and providing vaccination if available. And finally, define a clear pathway for screening, triage, testing, and management in healthcare setting. So I think I would like to end over here because I won't be going for home-based recommendations, because if you during the trial you think that patient can be handled easily at home, it's good to send the patient to the home, but with appropriate instruction, that is the infection control, home-based infection control, and that's a separate area, and strict instruction to the patient and caregiver should be given to at the time of discharge. Thank you.
Thank you so much, Dr. Seema. And I really apologize for rushing you through the last couple of slides, but we have just a few minutes to wrap up. We had planned to have more of a question, answer, and discussion with all our speakers. But before I move to the questions, just a very, very quick thank you to all our four speakers, Dr. Seema, Dr. Zara Hassan, Dr. Said, Dr. Aisha. Thank you so much to all four of you for, at such short notice, putting together fantastic talks and, really very, very important practical recommendations and guidance, which I think is going to be crucial for all our people attending today. So just quickly to go to the questions, and then I will request Dr. Sumaya, President of the MMIDSP, to close the session. But we have a question, Dr. Seema, for you, which is what percentage of disinfection should be used in laundry for actually cleaning the would you be able to answer that?
Terminal cleaning, for terminal cleaning?
Yes. For laundry, in the laundry, for cleaning. I think that's all it says. Yes.
Is it for the laundry or for the environmental cleaning?
For the laundry. So maybe,
terminal.
Maybe we could do laundry and then environmental cleaning. What percentage should be used in?
Yes. I have already mentioned that hot water of around 70 degrees centigrade can be easily be used for disinfection of soil linen. And the timing given for appropriate action of hot water is around 20 minutes. But if you can also go for use of low concentration of hypochlorite, and WHO recommends that the concentration of hypochlorite is around 0.05 ppm. It can be mixed with the water, and it can be used for disinfection of soil linen.
Thank you. Thank you very much. That's fantastic. Thank you, Dr. Seema. We have a question for Dr. Said, which is, do we know how the laundry was managed in the outbreak? So the unit in Khairpur, do we have any information? And maybe that could have been...
Yes, I think as I mentioned that the situation was not that ideal on the grounds. Asking question from here is entirely different when you see there and the real environment. So first
Yeah,
question,
so it wasn't
first
ideal.
question, they have the laundry or not proper laundry. So
Yes.
yeah, that
Yes,
is more
unfortunately,
yeah.
yes. I apologize for laughing about that, but yes, I think the
No,
first question
unfortunately,
would be yes.
unfortunately,
Yeah.
but just so unfortunately, things are but still we give them recommendation in the given circumstances and available resources. The same thing that our Dr. Seema mentioned, that we suggested that at least you should wash in warm water and use bleach, the easiest available disinfectant, which is not that expensive, is the bleach, and
Right.
that should be used. So they were not
Thank you.
properly following initially, but after the
They are doing it
instructions
now.
that now. Yeah.
Wonderful. Wonderful. Thank you so much, Dr. Said. Dr. Zara, two questions for you. One is that do we know the clade? Has the clade been identified yet? Is it 1 or 2? And also clarity about the use of blood as a sample for PCR testing for monkeypox.
Thank you for both questions. I do not know the answer to the clade. I believe that the sequencing was being done by the public health labs, and Dr. Said will have information soon. We are just offering a direct PCR, which will identify both clade 1 and clade 2. It does not speciate. In the question about is blood a good sample? No, because unless the infection is systemic in an advanced stage, you are not likely to get too many virus copies in a small blood sample. So it is not the preferred sample. Site-specific lesions are the best samples.
It's the best. Right. Thank you very much. Thank you very much. And Dr. Aisha, you answered the question in the chat, but it was about more details about the lesions identified in the neonates. But you answered that question, I think, yes. But I think you answered. But if you could just share with us, I think maybe other people might benefit from.
Correct. So the outbreak that Dr. Saeed had rightly pointed out, because he was also on site doing the outbreak investigations. So rightly pointed out that initially when these neonates, and many of them were premature also, so they were thinking of disseminated staph infection, and disseminated staph infection can present in symptoms in lesions similar to this as disseminated folliculitis. So that was the initial working diagnosis of the doctors there. Which Dr. Saeed rightly pointed out, since both the culture and the subsequent PCR of varicella was negative, then this is what led them to the diagnosis of monkeypox. So it was basically skin lesions that the news were investigated for.
Thank you. Thank you very much, Dr. Aisha. So just to all of you, the last few, again, I keep saying few minutes, but this is the last few minutes. The next couple of weeks are going to be crucial, right? So where do you guys feel that the focus ought to be? I mean, we've had, mashallah, 100 people be part of this webinar today. It shows that people want information, they need information, and I think the guidance this morning has been fantastic. But where do you feel that we need to now focus our attention, and what needs to be done next in the next couple of weeks, which is going to be so crucial?
So should I Should I answer that?
Please, anyone can jump in.
So I think now so the first the most important thing is to create an awareness. So people should know, okay, there's this new virus, not new, but there is something new that is emerging within our society. And it has to be the awareness has to be given cautiously, because people then stigmatize it that this is monkeypox. So remember that pox is also in circulation, very much in circulation, and this is far more contagious and far more commonly seen. So it is good to have a low suspicion of an index, because we are seeing local sustained transmission from human to human. But before stigmatizing or labeling somebody, the first important thing would be to identify it, to create an awareness so that people identify it. And then people just need to take some basic precautions like wearing a mask when in public and stay at home while the healthcare physicians or the healthcare workers investigate their lesions. So awareness, identifying, and then isolation. These are the three
Thank you.
steps that will contain the virus.
Thank you very much, Dr. Aisha.
And
Anybody
I would
else
like
from
to
our
add, I just want
Dr.
to
Seema.
add over that most of the time the breaches in the environmental and laundry cleaning and these protocol they are seen for the like sustained transmission of these outbreaks. So it is very important that in the Sindh area and the different Sakhar and Khairpur and other areas, I think training of healthcare workers and not just for the use of PPE, but also for the environmental cleaning, equipment cleaning, how to handle these in different kind of situation. It is very important, because I think there is a lack of these protocol over there, and that reason why we are continuously seeing these kind of incidences.
Natasha, I have a point of view.
जी, Dr. Said, please carry on.
आई थिंक डॉक्टर आयशा ने बहुत अच्छी बात की, लेकिन मेरा थोड़ा सा ना ओपिनियन स्लाइटली डिफरेंट इसलिए है। मैं उर्दू में इसलिए एक बात कर रहा हूँ ताकि अवेयरनेस सामने बात की तो कुछ लोग के लिए ये मैसेज उर्दू में भी ज़रूरी है। स्टिग्मा से बचने के लिए जो हम एफर्ट्स करेंगे वो काउंटर इफेक्टिव भी हो सकता है। स्टिग्मा से बचने की वजह से जो हम एफर्ट कर रहे हैं कि भाई ये एम्पॉक्स नहीं, पहले हम दूसरी चीज़ें रूल आउट करेंगे ना, तो यही चीज़ यहाँ पे हमने ऑब्जर्व की कि हम एक्सपेक्ट नहीं कर रहे थे, क्योंकि ये एम्पॉक्स हो नहीं सकता, और एम्पॉक्स क्योंकि सेक्सुअली ट्रांसमिटेड डिजीज अनफॉर्चुनेटली, तो ये भी एक दोनों चीज़ें बहुत पैरेलल हैं। तो हमें फौरी, स्पेशली अब जब इन्वायरमेंट आउटब्रेक का है, तो हमें अभी फौरी रूल आउट, एम्पॉक्स पहले रूल आउट करना, बजाय कि हम दूसरी चीज़ें रूल आउट करें। मतलब इसमें अगर आप देखें, जो हमारे पास सैंपल आया था वो चिकन पॉक्स, अगेन वही प्रेशर था कि पहले हम स्टिग्मा रूल आउट कर रहे थे, कि पहले हमने बैक्टीरियल इन्फेक्शन का नाम दिया, फिर हमने जोर लगाया तो चिकन पॉक्स पे एग्री हो गए, और आखिर में लैब ने कंफर्म किया कि ये एमपॉक्स है। तो ये थोड़ा सा सोसाइटी का जो प्रेशर है, स्टिग्मा, ये बहुत अहम रोल प्ले कर रहा है, लेकिन वो हमें डायग्नोसिस भी इफेक्ट कर सकता है। तो वी नीड टू डायरेक्टली कम टू द लैब। हमें इन्वेस्टिगेशन जो है ना लैब्स की लाजमी करनी चाहिए, और इस कम्युनिकेशन को ज़रा मज़ीद कम्युनिकेशन को स्ट्रेंथन करना चाहिए। दूसरा इंपॉर्टेंट बात जो मैं कहूँगा कि अपकमिंग डेज में हमें इन्वायरमेंटल सैंपल्स और जो भी इनक्यूबेटर्स हैं जहाँ बेबीज डील हो रहे होते हैं, उनकी प्रिएम्प्टिव और पहले से हमने वहाँ पे सैम्पलिंग करनी चाहिए, ताकि बच्चे जब वहाँ पे जाएं तो वो पहले से इन्फेक्टेड ना हो और बच्चे मज़ीद हमारे पास पेशेंट ना आए। थैंक यू।
Yes, thank you so much, Dr. Said. And I think you're absolutely right. I think but there is a bit of a fine balance. So I'm kind of in between what Dr. Aisha has said and what you're saying. I understand both perspectives, but I feel like, हमारे society में असल में stigma ही इतना बुरा हो जाता है कि, unless we are very sensitive and cautious, and then you're right, it's a very fine line by being overly cautious and then missing the diagnosis. But I think what this session has done is that it has created a very, very good, a way to identify cases and to follow them through, to isolate them. Dr. Seema has given, excellent advice on how to, isolate and prevent transmission, if you do have a patient who walks in to your center. But I think, again, one of the most important things that's going to be over the next couple of weeks is for everyone who's attended this session to go back into their institutes and their clinics and to start really having discussions and dialogue about, you know, what if a patient walks into our center, what are we going to do? Are we ready for it? So I think hopefully today everyone's been able to become familiar with what is required for these discussions, and that, you know, we all need to be working on it. We cannot be naive and assume that, you know, a patient isn't going to walk into our centers given the extent of the community transmission that's going on right now. So early recognition, appropriate testing, timely IPC measures, they really can make all the difference. I hope Dr. Sumaya is online, because I would just like her to close and thank her. Really, if she hadn't pushed for this and she hadn't coordinated with all the speakers, we wouldn't have been able to do this session so quickly. So as president of the MMI DSP, I'd really like to thank her for really bringing together this community of practitioners. And I really think that this is such a testament to the infectious diseases community, that, you know, we've got such an excellent group of people who have experience and knowledge, and they are always willing to share it to help others. So Dr. Sumaya, are you online? So to just close the session.
Dr. Natasha, thank you so much.
Thank you.
And thank
Lisa.
and really a big thank you to all our speakers. This was definitely short notice, but thank you. Our experts are always willing to teach, and they never shy away from such commitments, no matter how whenever we put them in a corner to participate in such events. But it's really heartful that they always come through. And thank you to our audience who have actually stuck through to the end of the seminar, and your participation has been very enthusiastic. So I'm sure कि आप लोग सब किसी ना किसी हमारे व्हाट्सएप ग्रुप से जो हैं लिंक करके आज यहाँ पर आए हैं. Do not shy away from posting your questions on those WhatsApp groups. इस सेमिनार की रिकॉर्डिंग हम अपनी YouTube के चैनल के ऊपर भी पोस्ट कर देंगे. I'll share the links over there. But please ask your questions, and you know, we hope that if you have any other follow-up seminars following this, you'll be a part of that as well. So I think with that, we can formally conclude. Dr. Natasha.
Thank you very much.
Thank you so much, Dr. Sumaya. Thank you. Thank you, everybody. Thank you. Excellent session. Thank you so much. Thank you. For that office. Luqman, thank you so much.